Okay, welcome to session 4. This week we're going to focus on antidepressants. Okay, just a couple of fun facts from lecture 4. I want you to memorize this slide. Okay, the least weight gaining second generation antipsychotics are geodone, Abilify, and Latuda. So I want you to memorize the mnemonic GAL, G-A-L. These are the least weight gaining second generation antipsychotics. Okay. Antipsychotics you should take with food is zyprasidone and Latuda. The least sedating second generation antipsychotic is Abilify. And Clozaril is the only antipsychotic proven to reduce suicidality. Okay. All right. So what I want you to do is take a look at bubbles here. Okay. Close your eyes right now. Just close your eyes. Now open your eyes, look at the bubbles, and write down the first 3 words you see. Okay. Just write it down. All right. And now I want you to pause this video and just do the test your knowledge check in and then come back. Okay. So pause it now. Okay. So true or false, medication classified as antidepressants are only used for the treatment of depression? No, obviously not. Antidepressants can be used for not only the treatment of depression, but also anxiety, eating disorders, and other mental health disorders such as post-traumatic stress disorder. Okay. Antidepressants must be used very cautiously with patients with bipolar disorder. Why and what are the implications? Okay, so SSRIs, SNRIs, antidepressants can potentially trigger a manic episode. If you have a patient that has a history of hypomania or mania or is diagnosed with bipolar 1 or even 2 disorder, you want to be really careful when you give antidepressants because they can trigger hypomania and mania. So the implications are you always want to assess your patients. Has there been a time when you had an increased energy and couldn't sleep for days and didn't feel tired? Are there periods where your speech is very rapid and people notice that you're speaking really quick, really rapidly? For instance, I speak really fast. Sometimes on the videos, I slow my cadence down so I'm not speeding through these videos, but my baseline speech is really, really rapid. So, but if my baseline was like, okay, how are you doing today, class? And I'm not intentional. And then all of a sudden I start talking like this and I'm telling you about different things in my life and I'm just talking super fast and I'm switching from topics to topics and telling you about my dogs and then I'm telling you about the sky and this and that. Well, you can see that that's rapid speech, and usually rapid speech is associated with racing thoughts. Okay, so when you have a patient that has this type of history, you want to be very mindful because they can have undiagnosed bipolar, and if you are giving someone who has bipolar an antidepressant, they also need to be on a mood stabilizer, or else you'll trigger a hypomanic or a manic episode. Okay, so again, the implications is that your assessment is key. You need to do your assessment, ask your patient, and this will be clearer in the next module when we talk about bipolar disorder. But for now, just understand that antidepressants do have the potential to trigger a hypomanic or manic episode. So you want to be mindful and make sure you're not giving this medication, antidepressants, to someone who has bipolar disorder or undiagnosed bipolar. And how would you know? Basically, do your assessment. And sometimes it just happens. Sometimes you'll give a patient an antidepressant and you will trigger a hypomanic or a manic episode. And even if you did your assessment, maybe the patient never had a hypomanic or manic episode in the past, but you triggered it. So it's okay. You're not the worst psychiatric nurse practitioner because this happened, especially if you were prudent and you did a thorough assessment. So what happens in an outpatient setting? You want a patient, do your patient teaching. Tell your patient, if you experience XYZ, contact us or go to the emergency room, depending on the severity of symptoms. All right. Okay. So next thing, true or false? Initial improvement always takes 4 to 2 to 4 weeks, not necessarily. So when you start someone on an antidepressant, it's more than just, achieving a therapeutic steady state. Some patients respond to antidepressants really quickly and you're like, this is impossible. It must be a placebo effect. And sometimes it can be, but sometimes it's not. Sometimes patients really do respond quickly to medication, and some patients really do take 2 to 4 weeks to see a full therapeutic effect. Usually, though, after 2 weeks, you see some change. It might be a very modest, a very small change, but you know that the patient's symptoms are trending in the right direction, and that's a decrease in symptomology. Okay. And so, what's the other factors involved in here if it's not just related to a steady state? Okay, well, you have genetic factors, right? So, sometimes people have gene drug interactions. It depends on what other medication are they taking. Are they taking medications that are inhibitors or inducers? What about their lifestyle? How long they've been depressed. These things all play into the psychosocial implications in terms of how quickly a medication will remit symptoms. All right. What is serotonin syndrome? Serotonin syndrome is an overactivity of serotonin. There might be too much serotonin in the synaptic clefts or an impairment of serotonin metabolism. This is a life threatening emergency. Okay. The patient will start to have mental status changes. They become disoriented. They can experience hallucinations. They can go into a coma. They can become very agitated. You have autonomic instability, such as increased heart rate, hypothermia, changes in blood pressure. Okay, they become hyperreflexic, they're uncoordinated, and then you have like severe GI symptoms. This is a medical emergency, and you need to educate your patients. And so serotonin is very long. What I do is I always like have my patients while I do telehealth. So while I'm on telehealth, I say, Google serotonin syndrome. Do you see that? Okay, these are the symptoms, and go over it very briefly. If you're an outpatient clinic and you're not doing telehealth, you want to give them some literature, you want to review it, they need to know it. I've never had a patient have serotonin syndrome, but it does happen, and it can happen. You start low and you go slow. That is the golden rule of psychopharmacology. Okay. All right. So the paradox of neurochemical imbalance. Okay. So the paradox and how we know this is just that depression is not just a neurochemical imbalance, right? It's not solely a neurochemical imbalance because you give an antidepressant, many times the drugs increase serotonin availability within minutes, but it might take days to weeks if this medication even works, if this particular antidepressant works, for there to be symptom improvement. And so this has been attributed to like a negative affective bias, right? And this is a focus on the negative. It's like you're in a black room and you only have a flashlight and there's this beautiful mural on the wall, but you can only see these little pieces of gray and black, and that's just like the dirt around the beautiful garden, let's just say, of the mural. So it's a focus on the negativity, on negative. You have negative thoughts. I'm never going to be good enough. Nothing ever works out for me. No one's ever going to love me. Things always go wrong. I'm not good enough. You have this negative programming in your patient's thought process. Okay. And so it takes time to change this perspective. And that's why it's so important to combine psychopharmacology and psychotherapy. Okay, particularly cognitive therapy, which really helps in restructuring your thoughts and shifting from a negative perspective to a more neutral or even positive effect. Okay, so I had at the beginning of this, I asked you to write down the first three words you see. And so a person who is like really worried about this class and super anxious might see terrified or despair or misery. Someone who's like super happy and really enjoying this class might see happy and fun and ecstasy. I doubt that you're going to see ecstasy in this class, but you maybe you just came from yoga and you just like are super peaceful and chill. All right. But this is that negative affective bias, right? Like that. If you're really depressed, you might see sad and despair and frustration. Okay. All right. All right. So when we think about antidepressants and depression, you're going to think about your ADPI, right? Your assessment. So you're going to assess your patient's symptoms. You're going to conduct a mental status exam. All right. But you're also going to look at the history of their current medication and their previous medication, any history of suicide attempts, any history of homicidal ideation or homicide attempts. You're going to use your screening tools. And again, any history of mania or hypomanic symptoms. Okay. Has this person ever been diagnosed with bipolar or bipolar 2? Does it run in their family? This is very important. You want as much as possible not to trigger a manic episode. Okay. And what if the patient is depressed and has a history of mania? What are you going to do then? Well, we'll talk about this later, but you're going to think about medications such as Lamictal, okay, for depressive bipolar. Okay. All right. So the symptoms of depression are usually, it's easy to remember if you remember the mnemonic SIGI caps. Okay. SIGI caps. I don't know if you guys know this, remember this from undergraduate. Okay. In terms of your diagnosis, remember we're going to look at our DSM-5 TR to formulate a working diagnosis. Okay. We want to rule out medication, physiological reasons, or substance abuse. We're going to rule out any other psychiatric disorders such as bipolar, okay, or post-traumatic stress disorder, okay, or grief, bereavement, prolonged grief. Okay, planning. We're going to consider the pharmacological options. Okay, consider the setting, symptoms, previous medication trials, the patient's family history related to medication, and side effect profile. So if you have someone who's really anxious and their sister is also anxious and their sister has been doing really well on Lexapro and tolerating it well, right? Like not having any significant side effects. You may consider prescribing Lexapro for your patient if it's not contraindicated, all right? And also if it makes sense strategically in terms of symptomology. Okay. All right. So, and then we get to our implementation. So, this is when you're going to prescribe your medication, you're going to conduct your patient education. Patient education is key for compliance, is key for understanding what to expect, managing expectations. Okay. You're going to refer for therapy if appropriate. When is it not appropriate? Well, if you have somebody who's highly psychotic, you're not going to refer them for psychotherapy initially. Okay. They need to be stabilized. All right. If you have somebody who's bipolar, has a diagnosis of bipolar and is in a manic episode, they're just not going to be able to take in therapy and it's going to be pointless at that point. Okay. Let's see. And you're going to schedule your follow up, especially if this is outpatient. Okay. And then on your follow up, you're going to evaluate the efficacy and any side effects, and you're going to adjust your medication accordingly. So when you're conducting your assessment, I think most of us know the PHQ-9. This is the widely used 9-item self-reported questionnaire assessing the severity of depression symptoms. This is most commonly used as a screening tool. Okay, we have the HAM-D, which is usually used in research and inpatient settings, although I have seen it used outpatient. Beck's Depression Inventory is another self-reported questionnaire measuring or assessing the severity of depressive symptoms. We have the Geriatric Depression Scale. Now, this tool is specifically designed for older adults and to assess depression in older adults. They have two versions, a 15-item and 30-item version. And then you have the Mood Disorder Questionnaire, and this is a screening tool to identify symptoms suggestive of bipolar disorder, assessing mood elevation, energy changes, and impairment. For me, when I see my patients in private practice, I have them do a screening I do the PHQ-9. I also do the mood questionnaire because, again, I don't want to trigger a manic episode. So you want to be very mindful and at least be as diligent and prudent as possible. Again, sometimes it might happen, but if you want to be prudent, you want to have a strong assessment, but you also want to teach your patients what to expect. Okay, you want to inform your patients, especially when you're putting somebody on an antidepressant for the very first time. Okay. All right, so here's your SIGI cap. So this is your symptoms of major depressive episode. You're going to look at sleep. So is there any impairment in sleep? Are they sleeping too much? Are they not sleeping at all? Okay, any change in interest, any loss of interest, loss of pleasure, and things they used to like to do. They love going to yoga. Now they don't really want to go. They love walking and playing with their dogs. Now it's like they're going through the motions. Okay, you want to see if there's any feelings of guilt, feeling guilty, like they're a failure. This also is connected to worthlessness, right? Feeling like they let their family down, they let their children down. They're not good enough, that kind of stuff. You want to look at their energy levels. Do they feel fatigued? Okay. If they have high energy and they're depressed, it's probably like more of a bipolar thing. Okay. Usually you see very low energy in depression. All right. You want to see a lot of times patients will report not being able to concentrate. Patients will report feeling like very foggy, a cognitive fog. It's important to figure out or to assess when did the patient start to experience difficulty in concentrating? If this is something long standing, then it's usually not related to the major depression, and it might be an indication of ADHD potentially. And so, what you would want to do is you would want to treat the patient for the depression and then reassess the cognitive or the concentration symptoms after the patient has full remission of depressive symptoms or at least a partial remission. And also ask them, like, when you were in middle school, did you get in trouble for talking too much? Did you get in trouble for daydreaming a lot? Did you get in trouble for talking? Is there any impulsivity? Did you lose your homework or lose your book bag a lot? That kind of stuff. All right. And then you want to look at any changes in appetite. Okay, so are they eating too much? Is there like a lot of emotional eating? Are they not hardly eating at all and losing weight? Okay, any psychomotor changes where the patient is really irritable, agitated, and they're moving a lot and fidgeting a lot, or are they just really slow and almost like they're moving through quicksand? Okay, any suicidal ideations, thoughts, intentions, plans? Okay, all right, so this is the clinical diagnostic criteria for major depressive disorder that I pulled out from the DSM-5 TR. I want you to take a look at it. Somebody breaks up with their boyfriend and they're feeling depressed. It's not necessarily major depressive disorder. You have to look at the diagnostic criteria. If the patient has had these symptoms for a 2-week period, okay, and they have 5 or more of the following symptoms, which we're really not going to get into, then you can formulate your working diagnosis of major depressive disorder. Okay. Otherwise, it might be like an adjustment disorder. And again, you want to weigh remember, it's this risk benefit analysis to psychiatric medication, right? Is the patient debilitating? Is the patient able to go to work? Is the patient suicidal? Is this something that the patient has to experience emotionally because there's a loss and they have to go through the grief process, what that might look like? Is this something that can be better treated with psychotherapy? Or is this where the patient's quality of life, the patient's occupational function and social function, the patient is debilitated and meets the clinical criteria for major depressive disorder? All right. So I encourage you to read the chapter in the DSM-5 TR on depressive disorders. Okay. It's important. You don't need to know it for the test, but it's important for you to understand the symptoms of what you're treating. Okay. It's not going to be on my midterm. And through the program, you'll have an assessment class where you'll learn about the different disorders. There's also differential diagnoses that you want to rule out, right? So, like an endocrine disorder, is the person have diabetes? Does the person have hypothyroidism? Okay, how are you going to know? You need to do thyroid functioning tests. Okay, you need to do a HbA1c. All right, is the person experiencing a neurological disorder like Huntington's, MS, Parkinson's, a stroke, epilepsy? Are they early onset dementia? Or just dementia in general, Wilson's disease? All these disorders can present with symptoms of depression. So you want to do your due diligence. Cardiac disorders like congestive heart failure, hypertension. If a person had a MI, these things can also cause depression. You want to rule out infectious inflammatory disorder like lupus, TB, AIDS, and nutritional disorders like pernicious anemia. And why do you want to rule this out? Because if you treat the core issue, if you treat the root physiological issue, potentially the depressive symptoms will dissipate. Sometimes it won't, and sometimes you'll still have to give the patient an antidepressant, but you want to rule things out. Okay. All right. So lab work, CBC, CMP, thyroid function test, Let's see, liver function test, kidney function test, vitamin D. Now, in New York, people will tell you, oh, everyone is vitamin D deficiency. So first, it's not true, but a lot of people are because, like the grayness and the snow, it's been a nightmare this this winter, right? But some people are significantly vitamin D deficient, okay? And so you want to give them supplements, all right? Vitamin B12 and folate levels deficiencies can contribute to mood disorders, and you want to do a tox screen, okay? All right. Are they abusing substances? Are they drinking to alcohol use disorder? Okay. And then there's also medications that can contribute that have side effects of causing depressive symptoms such as steroids, estrogen, antihypertensive, and Accutane. So antidepressant classifications. All right. So remember, antidepressants, we want to target our treatment, right? We're trying to treat depressed mood, hopelessness, worthlessness, despair, guilt. Some patients might have anxiety, but it's usually the depression that is driving the anxiety. Okay. Irritability, anhedonia, loss of pleasure, low energy, lack of motivation, appetite disturbances, eating too much, not eating enough, impaired concentration, memory, cognitive fog, and sleep disturbances. Okay. So the most well-known antidepressant is SSRI. Okay, and this is selective serotonin reuptake inhibitors. It increases serotonin in the synaptic cleft, or the availability of serotonin by blocking the reuptake channels on the presynaptic neurons. An example is like Prozac. Let's see, medication is usually given in the morning, but some medication can be sedating. So we'll get into it in a couple of slides. It might be given in the evening. Higher doses of SSRIs tend to cause sedation, and initially, patients may experience like GI symptoms like nausea and dizziness, but this usually subsides after 2 to 3 weeks. If it's not trending down, the patient might not be able to tolerate this particular medication. All right. One big issue with most antidepressants is sexual side effects. Men experience erectile dysfunction. Sometimes there's delayed ejaculation or difficulty ejaculating. In women have a difficult time achieving an orgasm. In general, sexual side effects are often unreported and providers don't ask, but particularly in women. Also, in general, there's a decrease in libido, decrease in sex drive. Hypertension can occur. These medications can increase blood pressure. They can also cause increased perspiration, but these symptoms tend to be dose dependent, like the higher the dose, okay? But more common side effects include insomnia, constipation, dry mouth. Some people get mild tremors. Some people get blurry vision and muscle weakness, okay? All right. So next we have SNRIs. They inhibit the reuptake of serotonin, just like SSRI, but also norepinephrine. Okay, and so this is venlafaxine, which is Effexor, and then we have Pristiq, and we have duloxetine, which is also known as Cymbalta. All right. Cymbalta is a good medication for a person who is depressed but also has chronic pain. The lowest dose of Cymbalta comes in a 20 milligram capsule. So if you're trying to titrate someone off, the lowest dose they can be on is 20 milligrams. And so from that 20 to 0, patients often experience discontinuation syndrome. And I've found personally, this is a personal vinaigrette, I found that patients really have a hard time coming off of Cymbalta. So this really shouldn't be a first line trial, especially for someone who's never been on antidepressants. I mean, if they have multiple failed trials, and they do have chronic pain, okay, then deluxe Cymbalta, duloxetine might be an option. But again, try to avoid it. Don't give it as a first trial medication. All right. I've had patients who are 20 years old on Cymbalta, and I'm like, do you have chronic pain? No. So what other medications will you put on? Nothing. Why? Why would the nurse practitioner do that? And so that's why you want to be a well-informed nurse practitioner. Okay. All right. So let's see. What do we have? Okay. Like SSRIs, SNRIs, there is an increased risk for increase in blood pressure. So you want to assess for all psychiatric medications. You want to get baseline, right? You want to assess for existing hypertension. Okay. The next medication is TCAs. So they inhibit the reuptake of serotonin and norepinephrine. TCAs used to be a first line medication or treatment for depression before the 1980s with the advent of SSRIs, Prozac. Um, because it is effective. It really is just as effective as SRIs. The problem is they have the potential to cause cardiotoxicity, such as heart failure, arrhythmias, MIs, strokes. Okay, but in an overdose, they can be lethal. So a patient takes like 7 pills or 7 day supply, they can die of immediate heart failure because it causes such significant cardiotoxicity. So they can have an arrhythmia and their heart stops and that's just it and they die. So we really want to be mindful when prescribing this. And honestly, TCAs are really not prescribed that much. Patients would go SSRI, SNRI, and before people go to prescribers go to TCA, they'll think about something now like ketamine. They'll think about okay, especially if somebody is really, really depressed and suicidal. We absolutely don't want to prescribe them TCA, right? And TCAs are sodium and calcium channel inhibitors, all right? And so this is the boom boom. This is how your heartbeat contracts and relaxes. So it can interfere with that and, like I said, cause significant cardiotoxicity and immediate death. Okay. One common medication that is prescribed is imipramine. Imipramine is really good for bedwetting, and that's because of the anticholinergic effects prevent the bladder from contracting and urine from being released at night. But again, you want to use TCAs with caution. Okay. Then we have MAOIs, which are monoamine oxidase inhibitors. These medications are also rarely used, particularly because they have so many interactions with food and other medications, but particularly with food, right? You can't have like cheeses and different dairy products and smoke products. And MAOIs have so many interactions with food. And the thing is, when you have this potential interaction, if a patient is on an MOI and has like smoked cheese or smoked Gouda or something like that, it can lead to a hypotensive crisis and cause death. So it's really not prescribed, only in limited circumstances. We have Wellbutrin, which is bupropion. We have mirtazapine. We have Spravato, which is your ketamine treatment, trazodone, and vilazodone. Okay. Wellbutrin is helpful because it doesn't cause any sexual side effects, but it also can decrease the seizure threshold. So if a patient has a history of seizures, you don't want to give them Wellbutrin because it can absolutely induce seizure activity. Okay. Mirtazapine is also known as Remeron. It's a H-histamine antagonist, and so it causes sedation and weight gain. And mirtazapine is particularly given to older adults because it helps with sedation, so it helps them sleep at night. So they give it to them at night. It improves their mood, but it also helps them gain weight. Okay, let's see. Trazodone. Trazodone is an antidepressant, but it's not particularly effective as an antidepressant. So you'll see it a lot of times in practice being given like 50 milligrams or 100 milligrams at hours of sleep at bedtime, because one of the side effects of trazodone is it is very sedating. And so we use it off label, if you will, to help patients sleep who have insomnia. Okay. And then we have vilazodone. Vilazodone is also known as Vibrid. It's an SSRI and partial agonist for serotonin 1A. Okay. It's a newer novel antidepressant